Video. Yeah, great. Okay, so anyway, let's forget that's there. So let me explain this. So Dr. Scale shared with me uh, your history, which is that you, again, 10 years ago had this heart problem, and then when you got back on medicines, the heart pumping function is still impaired. So we talk in my business about something called the ejection fraction. The heart, when it squeezes, normally it squeezes real vigorously, and when it weakens from congestive heart failure, it reduces its pumping ability. And we measure that in a percentage. Normally, when the heart squeezes, it should be about 50 to 60% of its contents, and yours is down to around 20 to 25% of its contents. They've tried with medicine to make that work better, but in the end, it's still kind of leveled out right now around 20 to 25%, which is down. It's also enlarged. Now, we discovered it's not from artery blockages. When they did the heart cath on you a while back, the arteries were fine, probably related to high blood pressure over the years. And over time, with high blood pressure, it can kind of weaken the heart. And I suspect that's what we're dealing with here. We've learned over the years that if you have a weakened heart, that heart can be at risk for heart rhythm irregularities, heart electrical problems. We talk about the pump all the time. Well, this is actually the electrical system of the heart. The way the heart normally beats, the way you get a nice coordinated heartbeat is electricity passes through the heart in a very coordinated fashion. And if the electricity activates the heart properly, it's going to squeeze, once for every one of those signals. What can happen sometimes, and actually this turns out to be the most common cause for death in America, and especially in people with heart failure, is once in a while on a bad day, there doesn't always have to be a good reason for it, the electricity can get jumbled, and the heart will go from squeezing normally into a quivering sensation. And if that occurs, it's like what you see on TV with the flat line. And if that occurs, they got to start CPR, and then the paramedic squad runs in and they shock the heart. And if you get there quick enough, you can restart the heart back to normal. Obviously, we don't want that sort of thing to happen to you. Most people, if their heart goes to that point and weakens like that and goes out of rhythm, the likelihood of survival is low. So what we've discovered is we can actually implant inside the body essentially what a paramedic does. I mean, it's like having a little paramedic inside your body, that if your heart should ever stop, the device would be there to start it back up again. It usually does it by delivering a jolt of electricity to the heart, but it can also do it other ways with pacing that you wouldn't feel. Important thing to realize is this device in a guy like you, it just sits there doing nothing, hopefully all of the time. So I go to another analogy. I think of it like an airbag in a car. So you can drive your car for years and years and years and never get in an accident. The airbag's in there, but it doesn't do anything. So it's essentially unnecessary. But the day where you really need it, you're glad it's there because the airbag can deploy and save your life. So a defibrillator in a guy like you is just like that. It just sits in your car, or in your body silently, essentially listening to your heart electrically. If it doesn't see anything problematic, it won't do anything. If it does, it'll essentially deploy the airbag, which in this case is a shock or a pacing therapy, which in most cases will bring you back to normal rhythm. Now, what we know about folks in your situation, once you've gotten them on the right medications and the heart's still weak, you carry this risk that you could get the heart equivalent of a car accident. And it varies on which research trial you look at, but I usually tell people like you, anywhere between 1 in 4 and 1 in 10 in the next 5 years are going to have one of these rhythm problems. Now, that means most people aren't going to in the next 5 years at least, which is great, but the odds are high enough to get people's attention. If you have one of these rhythm problems, most people don't survive, okay, if they don't have a defibrillator. Survival of what we call out-of-hospital cardiac arrest is about 5%. That means if you're relying on the paramedics and that kind of thing. Whereas if you have a defibrillator, it's about 95%. So you turn that survival on its head. Now, you don't need the defibrillator unless you actually have one of these arrests. And the arrest occurs maybe 1 in 4 to 1 in 10. So there's kind of some math in there you kind of have to think through. So just like with an airbag, there's a good chance you're never going to need it, but if you do, you'll be glad you had it. What the defibrillator doesn't do is it doesn't make you feel better. It's not going to improve the pumping ability of your heart. It's not going to keep you from having a hospitalization with what we call heart failure exacerbation, fluid in your what you had at the hospital a while back. It won't change that, but it could save your life. Okay, that's an important distinction. That some people, when they come to us, they don't realize that. They say, "Well, I want to feel better." Like, well, I'm not going to make you feel better in your situation with a defibrillator, but I might make you live longer. So if living longer is important for you, which it is for most of my patients I see, but not everybody, if living longer is important for you, this gives you a decent chance of living longer. So that's the purpose of putting it in. I never use the word need, just like from my perspective, I don't think you need to wear a seatbelt. It's a personal decision. I know in Ohio it's a law, but from my perspective, the idea of wearing a seatbelt is kind of a judgment call. So for you, a defibrillator is a judgment call. Is that something that meets your wishes? Recognizing all of that, so that's kind of the principle. So then the nitty gritty, which I'm going to dive into now, is what is it? How does it work? What's the surgery? What's life with a defibrillator? So if you're ready, I'll move on to that. Okay, we're with me so far. Okay, ready to move on. This is what it looks like, okay? It's a device that's implanted right here under the collarbone. There's a wire that runs out of the defibrillator, and it goes through the bloodstream. I'll show it on you. So there's the device. There would be the bloodstream, and the device goes around through the bloodstream and then down into the heart. It's all implanted under the skin. There's a surgical procedure that this book talks. It's not a book. It's a piece of paper. I ran out of the books they used to use. But this kind of goes through the nitty-gritty, and I'll describe it to you. But we do it in the hospital. It's about a 1-hour operation to get it in. And once we get it in, we keep you overnight, and then we check everything the next morning. If everything looks good the next morning, then we can send you on the road. It's usually about a little over a 24-hour hospitalization to get this in. The surgery is done under local anesthesia, but we also give you a lot of sedation for the procedure. And then the next morning we do a check on the device. We give a chest x-ray, and then the company that makes the device has a computer that can kind of talk to the device through your skin to make certain everything's working properly. I'll typically see you the next day unless it's a weekend where I'm not working, but most days I'll see you the next morning. And if not me, one of my partners, and we'll check everything out. If everything looks good, then you're on the road the next morning, usually between breakfast and lunch. The device then has a battery that for most people is going to last about, we'll say 8 to 10 years, sometimes a little longer, sometimes less. We check it both over the telephone lines. There's a machine we give you that plugs into your home phone. It'll send us information. And then we also test it in the office periodically. We bring you back in about a week, and then after that, about 3 months, and then usually every 6 to 12 months after that. So we can tell whether there's a problem building inside the device. We can also monitor for other heart problems, rhythm problems that might arise. We can tell how the battery's doing if the device is running low on battery. And then when it comes time to replace it, we'll typically just replace this unit, and we'll reuse the wire. On occasion, we'll run into a problem with the wire. Nowadays, probably about 1 in 100 will have a wire problem over the course of 5 years or so. The longer it's in, the more likely that we're going to run into a wire problem. These are in there flexing like this all the time, and if they ever break or malfunction in some fashion, we have to address that. But over the years, we've gotten pretty good at making and implanting leads so they behave reliably. But those are, some people call that the weak link in the system. That's probably still true. For most folks, living with the device doesn't change anything that you do. So you can still drive once you've recovered from the procedure. You can do all the things you're doing right now, except for a couple of things that might require adjustments. Do you ever weld? Have you ever had occasional weld? If you're not a welder, that's good. Welding's probably not a good idea with a defibrillator, but it's not an issue for you. If you talk on a cellular phone, you got to use the right ear, not the left. It's okay to use a cell phone, just try to get in the habit of using the right ear. It's not going to break anything if you use the left by accident, but the signals from the cell phone can, if they're close enough to the defibrillator, they can interfere with it and make it think your heart's out of rhythm when it's really not. I've rarely, if ever, seen it cause a problem, but it's still a good idea just to go to the right ear, just in case. If you forget, just move it to the right when you remember. If you go to the airport, you got to tell the airport security people that, yeah, I've got a defibrillator, and they'll tell you what to do. They generally do a hand search on you and pass you around. The implant itself has a small risk. It's not a zero risk. It's maybe 1 or 2% will get complications. We'll see bleeding, bruising, swelling. Rarely we'll see an infection, maybe later on, not always at the time of the procedure. And there's some discomfort early on that'll get better over time. Most people go home with a Percocet. We keep them on a pain medication for a few days, and then after the after they've taken that, it usually is just kind of a sensation of it takes a while to get used to that kind of sensation of the hunk of metal there. But for most people, after a while, it just becomes kind of part of their body, and they don't feel it anymore. For about a month, we don't want you to do anything real strenuous with your arm. We'll go through all this stuff again over and over, don't worry. We want you to avoid things like golf or tennis for a month or so. And then keep your elbow below your shoulder for about a month. You can scratch your head, but you want to raise your arm up like that for about a month. And then you're right back to normal. Mm-hmm. So I've covered a ton of ground right now. Yeah. Probably too much. Not too much. Okay. And what I want to do now is just kind of, I'm going to turn this off.